Hospital, and member of European Guidelines on Female LUTs. And to finish, Professor Alejandro Dorazio from Bahia Blanca, Argentina. And he did the fellowship in Clinique Saint Augustin in Bordeaux. He's director of CCU, Centro Cirúrgico Urológico de Bahia Blanca, and he is faculty in IRCAD Latin America too. So thank you very much for accepting the invitation. And I wish a very, very nice meeting tonight. You can make comments and questions during the presentation of Mandron. And Mandron, you can start now, please. Thank you very much.
Okay. So I will share first. So, first of all, I want to thank you for the invitation. It's a real pleasure for me to talk about this topic because I work on this topic for now more than 20 years. And normally we used to come every year in Brazil. And unfortunately, due to the COVID, this year we won't came, so that's why I'm very happy to be with you. I will talk about indication, techniques, and result, but essentially about techniques. You know quickly everything, so I won't talk about the anterior compartment, the median compartment, and the posterior compartment. Everyone knows this, and the grade, you know. So we imagine to start to treat at this level before we have to wait, but after we are allowed to treat them. We have a POPQ classification to use the codification of the prolapse. It's not very easy to use it, but I think it's a good issue to go on if we want to publish all over the world our results. I think we have to use now this classification. The surgery is a deal, in fact, because we have to deal with the three floor. We have to deal with the anterior floor with the cystocele. We have also to deal with the hysterocele and the rectocele. And you see that we can place different meshes, the posterior meshes here, and the anterior meshes. We'll see that we can place or two arms or only one on the right side. I used to place the meshes like this. At the same time, it's possible to imagine also to do the treatment of the incontinence. It depends, and in France now the recommendation are to say that we have not to treat at the same time the stress incontinence. We have to do only the surgical prolapse first and then the incontinence. But we can talk about this because I think it's difficult to propose to a patient coming from prolapse and incontinence to say, I won't treat your incontinence, I will just treat your prolapse. Also, a question is today is to say, is it necessary to place the posterior mesh if there is no rectocele? And we have a trial in France, a prospective trial with women who have only cystocele or hysterocele without rectocele. And we are doing this trial to answer this question, because right now I propose always a double mesh, and I will explain you why. The evolution of the sacrocolpopexy, in fact, you know, it started in 1957 in France by Hamelin and Huguier, and at the beginning, the technique was the fixation of the isthmus of the uterus to the sacral ligament, only with thread. But they saw a lot of recurrence in the anterior floor, and then they imagined to place a mesh posterior to the bladder. Then you see it's 10 years after, it's Huguier and Scali who developed this technique. And Blondon and Scali developed again with several synthetic meshes, but we have seen that if we place only an anterior synthetic mesh, I published this with Dr. Villet in 1999, we have seen 30% of recurrence to the posterior floor. That's why at that time, so 22 years ago, we said we have to place two meshes, anterior and posterior, at the same time. Concerning the evolution of the technique, I want to say, I think the picture is not very good, but just to show you the glasses, I'm now working with a 3D scope for now 5 years. We work with Broad-Esculap 3D scopes. It's really fantastic. And I must say that laparoscopic approach must be modern. You see also I'm sitting on a chair just to have the arm along the body to be comfortable. Here it's for a prostatectomy, but it's just to show you that the position must be comfortable. And if you can have the table download very important, then you can work easily. What are the arguments for the laparoscopic approach? As I said, the vision, the quality of the vision, and we'll discuss concerning the robot. But for me, what is very important is the vision. You have the same vision now when you are doing with robot or when you are doing with 3D scope vision. What is important for me and what is an advantage for the laparoscopic approach is the dissection, because with the dissection, I really touch. I have the feedback, and we will discuss concerning the robot. But for me, it's difficult because sometimes you need to feel very well instead of seeing only. For the quality of the hemostasis, for me, you will see I never place any suction or aspiration. And now we talk about the vaginal access, and now we know that it's prohibited to place a mesh by vaginal approach. That's why now quite all the surgeons are doing this technique by laparoscopic or robotic approach, because we know that it's the best correction, which gives a good vaginal axe, and which can give a good result for the long term. We'll discuss about the time of the surgery, and we'll discuss also about the cost of the surgery. So I will start. We have very few contraindications, and we can discuss about it. For example, the age. For me, after 85 years old or 80 years old, it depends on the trophicity of the vagina. But if the trophicity is not good, I think you have to pay attention to this, because you can have a vaginal ulceration, and then it's not a very good idea. And you can do a vaginal surgery without mesh, and it can give good results if the patient is really old. Contraindication can be the morbid obesity and multiple abdominal surgery. I ask always before the surgery, small things, ultrasonography, to look at the kidney, at the bladder, and the uterus. Why? Because sometimes you can find a huge uterus, and if you have a huge uterus, sometimes it's important to discuss with the patient before the surgery to say, perhaps we have to do a subtotal hysterectomy with the preservation of the cervix. That's why you have to have an exam of the cervix systematically before the surgery. Also, I ask for the kidney and the bladder. I must say that in 22 years of surgery, I discovered three kidney cancer at the time of just doing the surgery for the prolapse. So that's why it's very important, because it's a functional surgery. You could not pass with a functional surgery with a kidney cancer. So at the same time, I will ask always a CBU, which means a bacteriologic exam of the urine, always a urodynamic test, and now we start to do dynamic MRI, but we prefer to have the MRI for the prostate, and it's not very easy to have the MRI. And I think if you are a good clinician, in fact, with the blade, you can do a good examination of the lady with that, and you don't need to have the MRI, but it can be important. So we will start the technique, and I will show you first the laparoscopic approach. What is very important is to place your patient in Trendelenburg position. It's very important to have at least quite 25 degrees of Trendelenburg position. We use bag to place our instruments. I must say that I'm left-hander, and you see what is important is to have an easy access to the bottom and to the vagina. That means that the patient must be about 5 centimeters out of the table to be able to mobilize the blade. I will place, for laparoscopic surgery, I will place 4 ports. One port will be a 10 millimeter port at the level of the umbilicus, and 3 5 millimeter ports, one at the mid part in between the optic and the pubic bones, and 2 really lateral as possible. It's very important to place your ports at the level of the iliac crest really laterally, because you have a lot of suture to do, and if you have a large triangulation, it will be much more easier. At that time, I was doing with the Veress needle. I'm still doing with the Veress needle, but I know that the young generation must do mini open laparoscopy. It is the same. So the first thing will be the preparation will be the fixation of the uterus and the sigmoid loop to have a good exposure. So you will see here it's another port, the medial one. And you see that we have a good triangulation at least minimum 60 degrees in between.
Eric,
yes.
You use your pneumoperitoneum. How's
yes.
the pressure? About the pressure?
It's 12 millimeter. 12. So when it's ready, so I have no preparation of the bowel, no preparation. The first thing is to fix the uterus. I use a straight needle at the level of the pubic bones, really high, as close as possible to the pubic bone. And I will transfix the uterus and fix it up just to expose. And you will see that with this technique, it's a self exposition. The second fixation will be here at the level of the round ligament. Here you see the round ligament on the left side, okay? The epigastric are somewhere there, so you have to be outside of the epigastric. And then I will fix the sigmoid loop just with the part of the fat part of the sigmoid loop. You don't go through the rectum, okay? And you refix it, and it must be really down. Very important to avoid to cross your instrument. And here we just place a small grasper. We don't do any knots. We just place a small grasper. And we'll see that now. I will show you. You see the exposition. You see perfectly the Douglas pouch. You see perfectly the rectum well exposed, the uterus. And in fact, you won't have to mobilize anything. That's why I prefer to always do this, because it's very important. It's a functional surgery. You could not have any injury of the bowel and so on. So you must pay attention to this. So the next step is the sacral preparation. The first thing will be to do an opening on the peritoneum at the level of the sacral ligaments. And here you will see that we will just work with the pressure. We just work with the pressure. I am left-hander, as I said, so you see in my medial hand the scissors, and on my right hand a bipolar grasper, okay? And my assistant is on my left, and she has only a grasper, and she will have to grab and to do traction, to do a big traction. You see the traction she has to do. You see very well the sacral ligament. Here, what is important at that time is that you can have here the crossing of the left iliac vein. So you must pay attention. Here you have the medial sacral vein, and pay attention to there. So what you have to ask to your assistant is to do traction. And what I want is only to follow this typical aspect of this arachnoid space. As I said, I never use any suction device for this surgery, never. I'm just looking for this. And now, second step will be to do the traction. You will see the traction of my assistant. And you see here, when you do the traction, you go, and the direction is to go towards the uterosacral ligament on the right side. If you follow this arch, you see the ureter is here, so you have really far. So you have just to incise this, and then when you will arrive there, what is very important is to go down under the ligament and not outside. If you go outside, you will have injury of vessel. When you arrive here, you just have to go towards the Douglas pouch and to do a horseshoe-shaped incision, in fact. Okay? So you will see, just follow this. So now it's the incision. It's very easy time. You see the ureter. The ureter is here. So we are far from the ureter. You see this, and we just have to do the incision. And as I said, just here, you pass under the ligament, and I will open until I will reach. And here, you see what is important is to do a large and deep incision. Very important to do a deep incision because you need to have this tissue to be able to do the peritoneization at the end. If you just incise the peritoneum, you won't be able to do the peritoneization. So you see how deep is my incision. Here, it's very important this time. Here, it's all this fixation are the fixation to the sacral, uterosacral ligament. Here, you have some vessel. So pay attention, stay close to the rectum and just do the incision there. So do the coagulation with your bipolar and do the incision. It will free the rectum. You will see. Go slowly, and you see that now the rectum is quite free. So now it's the time to do the incision of the Douglas pouch. So you see that my assistant is lifting down. And here, pay attention, because when you do the incision, immediately what you are seeing here is the rectum. So at the very beginning, I just create the space and I don't place the blade at the very beginning. And when the when it's done, now I will introduce a blade. It's a metallic blade. I will show you. It's a metallic blade. And I place. You have a question? Yes.
Why you don't put the blade before the incision of the peritoneum? Before the incision of the peritoneum.
I think that you may have injury if you are because sometimes you can push the rectocell and push the rectum, and sometimes you can imagine it's a peritoneum, but in fact you have the rectum just behind.
Okay.
Okay. So for me, what is important is to try to find the layer to open just the peritoneum, to let the gas get in, and when you start to see this arachnoid space, then I will place the blade.
Okay, thanks.
And you will see. At the beginning, it's difficult because you have no place. Huh? So what is important here is I will show you. What is important is not to go down. If you go down here, you will enter in the rectum. What you have to find is this aspect, this typical arachnoid space, and in fact you have to go as high as possible, as close as possible to the vagina. But at the beginning, the blade is difficult because you have to ask your assistant to lift as maximum as you can the blade. Then the scissors will be parallel to the blade. At the beginning, the scissors is not parallel; it's in contact with the blade, and that's why it's so difficult to place very well your assistants. And slowly you will see freeing. You start to free, and every time you will replace the blade. You see here, I replace the blade, and then slowly my scissors will be quite parallel to the scissors, to the blade. And here what is important is to stay medial. You will stay medial and you go as down as possible. And then at one time you will see it start to be difficult to dissect. That means that you are at the end of the dissection of the rectum, and then you will have to go on both sides to find the pelvic floor muscle. So here you have to pay attention because you can have the pedicle, inferior pedicle. And sometimes if you have a big rectocell, you can have enlargement of the rectal cells. So that's why it's very important to go laterally from the rectum. And at the end, you have this typical aspect with as I said, like a face with the nose, which is the rectum, and the two eyes, which are the two fossa for the muscular part. But I will show you the dissection with the robot. I think the film is better. The video is better with the robots. So then we will place a mesh. So the mesh, because I'm left-hander, I will start by the left side. So here it's not. I used to work with two needle holder. And the mesh is 6 centimeters large, and it's like an Eiffel Tower. It's 6 centimeters large and 6 centimeters high from the large parts, and 16 centimeters for the total length. So here, this mesh is polyester mesh. We can place two kinds of meshes, or a polyester mesh or a polypropylene mesh. Now, at the superior parts, we have to catch the uterosacral ligament on both sides. And here you have to pay attention to be not too deep, because if you are too deep, the risk is to be through the vagina and to have several years after to have infection of the. So that's why it's very important that I used to place a blade, a glove on the blade. And at the beginning of my experience, I was asking the nurse to take out the blade to be sure that the thread was not through the glove. Okay? If it's so, you have to take out the thread and to replace another one.
May I have a comment?
Yes,
Yeah,
please.
Well, first of all, I agree for the majority of the steps that you performed, because I completely, it's similar. I put the probe at the beginning, as the other colleagues asks, because I think that it's easier to develop the plane when you have a probe into the vagina and the uterosacral ligament is evident. So, however, it's not a problem. This is only my experience, but it's not so important. But what is really different for me is that I don't put the mesh on the pelvic floor, and I fix the mesh on the vaginal wall. I know that it's a very debatable topic, and there are two lines of thinking about. And I know that the reason of fixing the mesh on the elevator animuscle is due to the fact that it's to avoid any kind of extrusion of the mesh into the vagina. But I had not this experience, and I have a very, very low extrusion rate of the meshes. And if you fix the mesh in the right plane into the posterior vaginal wall and with an absorbable suture, and in the last 5 years, I had no extrusion. So I think that this problem is not relevant, especially if you don't remove the uterus, as in this case. And the second reason is that I don't like to put a mesh on a muscle, because I am afraid about the pain that sometimes is reported in many studies. Sorry for my long comment, but it's a point in which I disagree with you, and I am convinced that in your hand this is the best procedure, but in other hands it's possible also to perform another kind of procedure. Sorry, Eric.
No, it's a great comment. I like very much. I must say that we were fixing the mesh, a posterior mesh, to the vagina 20 years ago, and we had some erosion, and that's why we have done the fixation on the levator animuscle, just to interpose the mesh in between the vagina and the rectum, and to avoid any fixation. But perhaps it was not the reason, the main reason. But with this fixation, we have not more any ulceration if it's well done. The ulceration you can have is always when you do a mistake and when you transfix the vagina, and because it's a non-resorbable thread, then you will have infection of the meshes.
But you use not reabsorbable suture.
Exactly. We use Mersuture 2.0.
But I use reabsorbable, so I use different kind of suture. So probably this is the reason. So for me, it's not a problem if I transfix the vagina, and generally it doesn't happen. But if I do, or my assistant do sometimes in the first experience, nothing happens, because in some days the suture is completely absorbed. So The reason of the erosion is due to other facts and not to the suture.
And sorry, Elisabetta, at the time you don't lose the tension using absorbable stitches?
No, nobody happens, and I put 4 stitches, 4 sutures, and 2 very deep, and 2 at the. If I maintain the uterus, like in these cases, I put on the cervix, and then I put the traction, and I think that there are no studies on this, but I think that after some days, the mesh is completely adherent to the vagina, and then you don't need any other things to suture it. So the suture needs only for some days, and I think that in no more than 2 weeks, they are completely disappeared, and the mesh is well fixed to the vagina.
Nice comment, Elizabeth, because for me, I use only Prolen, like the mesh and the fills, and the suture. So for me, your comment it's very nice. Which kind of suture do you use? And
Vicryl.
Yeah. Vicryl, incredible. For me,
and there is no problem for sure. I have I don't know how many procedure I have done, so many in the time, and I started with the not absorbable, and the problem is that Eric is right, because if you transfix the vagina, the suture will remain for forever, you know. So. And sometimes the infection is due to the suture, and it's not a mesh extrusion. So it's the suture which can provoke some kind of infections and so on. And so I think at the beginning in 2000, I started with absorbable, so with the normal Vicryl, and I had no problem, and you have no problem with the fixation of the mesh on the vaginal wall. The most important things that you have to be sure that the mesh is adherent to the vagina. So I put 4 stitches.
Okay.
Especially on the posterior vaginal wall, because in the anterior is easier, because it's due to the position of the vagina, because when you put the traction on the sacrum, the anterior vaginal wall go down, and so in the anterior vaginal wall you can put only 3 stitches if you want, but on the posterior you need 4, and with 4 you are sure. So okay, I think.
Which kind of material?
What kind of mesh?
Yes.
Yes. Okay, I used a lot of different mesh in the time, and generally I like polypropylene. And I don't like the ultralight. They are not good for sacrocolpopexy, because they are too elastic, and in the time the mesh changed the shape and became like a tight cord, so it's not good. And but for a long time I use also PVDF. And it's good too. So I think that the majority of the mesh which are available on the market with also polypropylene or PVDF are good. So it depends only on the shape of the pores. They have to be big enough, as Eric has in these figures, are perfect, but not too many light, because otherwise I think that from the functional point of view is not the best choice.
And you, Eric, which kind of meshes do you use normally?
I'm using polyester mesh. It's a polyester mesh. I use also polypropylene, but I prefer polyester. I think it's easier to work with. I like very much your comment, but I must say that I'm convinced right now with the non-resorbable thread, but perhaps I have to go on and perhaps to try with the resolvable thread. But I've done also more than 2,000 cases, I think. And in my town, another surgeon was doing the surgery with Vicryl, and we have seen some recurrence. But perhaps it was the beginning of the surgery, of his experience, and perhaps he was not doing well. So I don't know exactly. I don't know, and perhaps if you have no infection, perhaps it's the best way. But I must say that I have very few cases of infection. I think I have less than 5 cases in 20 years. So I don't know.
I completely agree with you that the experience is the major way that push us to continue with the technique that in your hand is the best. So I am convinced, but I am also convinced that you had this bad experience at the beginning of your experience, and probably with your experience now, you could do everything without any problem. And exactly. I know very well your procedure, because when I started many years ago, I went in France, and I learned the majority of the laparoscopic approach in France, and they performed your kind of procedure. And I changed by myself because I started with the abdominal colpopexy, and during the abdominal colpopexy, I was used to perform a different procedure. So in the time I changed, so I put together my abdominal experience with your laparoscopic approach, and I found, I don't know, a mixture. But I think that probably in a good end, both procedure work well. And the only question that I have for you is, in how many cases do you have pain during the defecation or pelvic chronic pain in your experience with this kind of procedure?
I think the position of the thread on the muscle is very important. You are right. At the beginning of the experience, we were placing the mesh on the pelvic, on the levator and a muscle very laterally. And here you have the fibers, the red fibers, and when you take these fibers, then it can give some pain. What is important is to place to fix as high as possible on the noyau fibreux central, as we said, of the périnée, as high as possible. Then it's more a tendon, it's less muscle, and then you have no pain. I must say that I have no pain now, but I changed 20 years ago. I was not placing the mesh, and at that time also we were crossing the rectum with the mesh, and we had a lot of constipation, of difficulty of exoneration. And when you fix very anteriorly the mesh as high as possible, then you have no more problem with the constipation. That's why it's very, very important to place well this mesh. And the question is now, to answer the question, is it necessary to place this mesh? For me, the posterior mesh is important because all the pressure are going posteriorly. And in fact, I can't show you today, but I have a video with a section of the mesh there, just after the large part. It was not a polypropylene mesh, it was a polyamide mesh. Probably it was the quality of the mesh. But that means that sometimes if you do a big pressure, you have a very big tension. And what we imagine is that it's the fixation, the force is going towards the sacral ligament, with the second force towards the uterosacral ligament, and with the third force towards the pelvic floor muscle. And in fact, all this pressure will help against the pressure. That's why I'm still imagining that the posterior mesh is important. And in my series, I I have quite no recurrence of the posterior floor. I have about 10% of recurrence anteriorly, but quite no recurrence posteriorly. But okay.
I completely agree with you. In this case, I completely agree, because I think so that you have to put the posterior mesh in any case. And I think so that the vector force, which are on the vagina, can contribute to develop a rictocele in the time if you don't put the mesh. And I think so that it's important to put the mesh also in the anterior, on the anterior aspect, because I have a little experience. I don't know if you remember that some years ago, there was a tentative to use absorbable mesh for colposacropexy. I don't know if you remember about this. And so in some cases, I decide to put one mesh reabsorbable and one mesh not reabsorbable. And after 10 or 15 cases, I stopped the procedure, because in any case, where I put the absorbable mesh, so in the time it disappeared, they had a recurrence on that compartment. So what I mean is that you have to perform a complete correction of all the compartment in any case. And so with the mesh on the anterior and one on the posterior. This is my point of view, and I'm really convinced about this. Yeah.
Great. I'm really happy to your comments, because I totally agree with you.
Yeah.
So I think we have to go on if we want to talk about also the robots. So if I've just done the peritoneization of the posterior aspect of the large part of the mesh, you see, it remains only the tail of the thin parts going towards and here I start the peritoneization, I let the thread of vitral there, and I will do the windows in the two parameters. You can pass only on the right if you prefer. I don't know where you are doing this. Personally, I was doing with Richard Villet while we were doing this surgery with open surgery 25 years ago. And I have done exactly the same with the laparoscopic approach. Also, I like this bilateral fixation, because I think that the uterus is well supported on both sides, like the arm supporting your child. With two hands and two arms, it's easier to support. So for me, it's more symmetric and more logic.
But for the FCAS, there's no difference if you put in both sides.
There is no difference, but what is important is the fixation to the isthmus. We will discuss thereafter. So okay. You see here.
If I can come, I'm sorry. May I make a comment? Sorry. Okay, I agree with Eric that I prefer to have the bilateral, as he told about, and I think that there are two reasons. Because the first reason is that you have a very good position of the uterus in the pelvis. But the second reason is that if you put the mesh only on the right, you have to put many stitches on the anterior vaginal wall to the mesh, because otherwise the mesh can detach and move on the right. If you perform a bilateral approach, you don't need, because it's enough good stitches on the isthmus, as Eric said. And so at the end of the procedure, the time that you had to perform 2 holes is better than to have more stitches on the vagina. This is my point of view. But probably at the end of the procedure, the results are similar with the...
Yeah. I perform only 1 hole in the right, and I never had a problem. And in my perception, I think if you cut the mesh to put in the 2 holes, I don't know. I think I am debilitating the mesh. I don't know. I think that if I have all the mesh, I have more strong mesh, but it's a perception. For me, it's the same.
So it depends on the shape of the mesh that you use. When I perform this procedure, I use a rectangular mesh, and I cut the mesh as I want. It's not a Y mesh, it's another kind of mesh. So I use different mesh when I perform uterus preservation, or if I perform hysterectomy and then I put the mesh. So I agree with you. It depends on the kind of mesh that you use. But I think that really, I am convinced that at the end of the procedure, the anatomical results is similar if you pass on both sides or one side. But, you know, I like to perform both because I think so that it's more aesthetically.
Yes, it's more beautiful. But for me, it's only that.
Yeah.
Okay, we go on. I will just give you some small comments and small technical aspect. Here, what is important here to find the good level is to ask your assistant to do a traction here at the level of the isthmus of the uterus to make tension on the vagina. Then, when you have a good tension, with your other hand, you will lift up the bladder, and then it will open. And at the very beginning, again, I won't place the blade. Because if you place the blade, at the very beginning of my experience, I have had 2 or 3 holes here in the blade, in the bladder. So that means I like to start the dissection very slowly. And then you see the hole on both sides. You start to find this arachnoid space, and when you have this, then you place the blade. You see now the right layer is just there. You see very well this layer here.
Nice.
And when you have this, now you have to place, and here you have to pay attention to place the blade in the anterior part of the cul-de-sac, because sometimes your assistant can place the blade in the posterior cul-de-sac, and then you can have the cervix. You see now the blade coming, and now you see very well that while you will lift up the bladder, you will find very well the good layer.
Which is your limit to dissect the anterior vaginal wall?
The limit is the balloon. You will see the balloon. What is very, very important is to ask your assistant to mobilize the blade, to push on it, and also to turn on the left and on the right to show the lateral aspect of the blade to see very well the dissection. Because here you will see, sometimes you can see the ureter. So you see now the lateral aspect of the blade. It's very important to detach laterally. And now you can start to see here the balloon. That means that you have not to go after this dissection. If you go, when you arrive there, you see that it starts to be difficult. So that means that you have not to go more. And when it starts to be difficult, that means that you are behind the trigone and you have to stop. Because if you go on, then you will have an instability of the bladder. So it's enough. And you see very well the balloon there. So for the anterior mesh, I will place five ports. Five stitch again with the mersuture, and for the first one I will do several points. You see, first one and the second one and the third one, just to have a good fixation, because I think this point is the most important point. really the medial one. And here it must be only fixed to the vagina. Pay attention to the fixation. When it's a fixation with the bladder, then you will have an injury, and then you can have an extrusion through the bladder. So it must be only a fixation to the vagina. And then you see here, I will ask my assistant to mobilize the blade on the right side to see the left side. And here I will place the thread. So this mesh, as I said, the posterior mesh was 6 centimeters large. This anterior mesh is only 4 centimeters large. And you see, I place separate points. You have seen some teams placing a running suture. Personally, I prefer to place separate points. I think it's preferable to expose very well the mesh and to place. And you see, the mesh must be flat. It's very important to have a flat mesh and then to fix at the superior part. And this part is very important. Look here, we'll fix the superior parts. And then what is important is to go to the isthmus. Here, we'll have to fix, we are very close to the uterine artery, and then a third point in the isthmus. And this point is very important. You must be a very good point, and this is very important. If you don't do this good fixation, the risk is to have a prolapse of the uterus in between the two meshes. That's very, very important. So you see here, you go really in the isthmus of the uterus. So it depends of the length of the prolapse. If it's a very big prolapse, it can be 2 or 3 or 5 passage. It depends. It depends. And here, the last one really deep, you see, in the isthmus of the uterus. And then when you have this, you will see that the mesh is really perfectly placed, flat, and totally fixed to the uterus at the level of the isthmus. And now it remains just to pass the 2 meshes on the 2 holes on both sides. So it's easy because you have done already the passage. But as you said, it's possible to pass only on the right side. But if you pass only on the right side, you have to pay attention and to place and to fix very well with a lot of points here to the isthmus. And then it's time to do the fixation to the sacral ligament. Here I like to recut a little bit the mesh. It depends to adjust exactly at the right side of the prolapse. And now for this point I use an extracorporeal fixation, but it can be intracorporeal. But I'm still doing extracorporeal, even if I'm able to do the knot inside. Here it's also a non-resorbable thread. It's a Mersuture 0. And for the fixation, here you have to pay attention to the tension. First, I will place the posterior mesh. And the posterior mesh, you place it, you fix it as it goes, without any tension. You see, just you place it like as it is. But for the anterior mesh, you have to balance a little bit more because you have to reduce the abdominal pressure. So you see that I will look anteriorly and look at the level of the sacral ligament and just do a small tension, but a small tension, not nothing. Because if you don't do any tension, you will have still a cyst cell, in fact. So you have not to do tension, but a small, very small tension. And then I'm just doing a rudder knots, and I will fix it like this, but you can do intracorporeal knots, there is no problem. And you see now that very well the mesh, which is fixed, and I will add one loop to fix it, recut, and then I will use the vicryl, which is already placed to start the peritonization. You remember I placed the thread for the posterior closure of the Douglas patch, and I will just have to take it. So I recut the excessive length of the mesh.
Eric, what do you think about the tackers?
I don't like tackers. You can have infection, you can have pain, and I think you are surgeon, so you are able to do. And also, it's a cost. And we have done an economic examination in our clinic, and I was the only surgeon using only thread, and my colleagues were using tackers. And in fact, my surgery was okay for the clinic. They were having some fees at the end. With tacker, they have no. The tacker use the fees because it costs. So in fact, it's not good and it costs.
Okay.
So for me, no. I just want to place only a thread. So here you see the peritonization.
Sorry, excuse me, Eric. Elisabetta, do you use a vicryl too to put the mesh in the promontorio?
No. On the promontorio, I use a not reabsorbable suture, and you can decide what you want. And general, but it's for sure not reabsorbable because everything is fixed on this suture.
This is the point.
Yeah, and regarding the use of tacklers and so on, I use it for sometimes some kind of these devices.
Yeah.
And I use the uplift that it's very easy to be used. And I think that, as Eric said, that generally we don't need.
Yeah.
But I encountered some difficult cases in, for example, in patients with previous surgery for example, for tumor of the colon or peritonitis due to appendix or some other kind of procedure which was abdominally performed. And in some cases, the visualization of sacrum is not so easy. So only in these cases, when I don't want to have when I have not a good exposure of the sacrum, I use this device. So I have in my operating room, and I used probably in the last year 3 or 4 times, no more. So just in case I need. And sometimes when you perform a lot of procedure, you can have the cases in which it's difficult, and in this case, you can use it. And I had no problems with this tacker. And so I think that they can be used. But I agree that the cost sometimes is excessive, and it's better to put only suture, and you have no problem. And the other difference with Eric is that when I put the suture on the anterior vaginal wall, I put only 2 stitches. I agree with him that it's better to have a separate suture, not a continuum, because the mesh has to be flat. Completely agree. But I put only 2 stitches in the distal portion, so close to the bladder, and then 1 only one suture directly in the middle of the uterine cervix, and then I pass the two arms, but one on the right, on the left, and in this case, the traction on the cervix is important, and I had never problem of a prolapse of the uterus into the meshes. However, I agree with him that if you put the mesh only on one arm, you have to put more stitches, as Eric do, and probably more than him. Yeah.
I would like to make a comment about tension of the anterior mesh. If you don't put, to start the surgeons to starting this operation is some difficult to understand how is the tension. Because if you don't put a lot of tension, you can have a cystocele. If you put a very, very strong tension, the patient can be incontinent. So it's a little bit difficult to, in the start, in the beginning, understand what, how is the best tension for this anterior mesh.
I will answer. For the posterior mesh, don't place any tension, no tension. Even if the mesh is like this, no problem. Just let it like this. It's just to interpose like a mesh when you are doing hernia repair. It's just an interposition. For the anterior mesh is different. You have the trennal elbow position as you are seeing on the slide. So the prolapse is reduced. But you have also 12 millimeters of pressure pushing the vagina outside. So if you just let the mesh anteriorly as it goes, you will have the cystocele quite pushed by the pressure, intra-abdominal pressure. That's why you have just to reduce a little bit this cystocele, but not to have a big tension, because if it's too big, then you will have the bladder totally straight, and then you will use incontinence. So I mean, just a very small. You look at the mesh, at the anterior mesh. You look at it, and then you place it on the promontory, and then a small tension, and you fix it. Okay? It's just no big tension, but not no tension. Okay? It's just an experience, but you will see. It's better to let a small cystocele than to have nothing and to have a straight correction and then to have incontinence. I think it's better to have a small cystocele. The patient will be perfect. When you will do the examination, you will say, perhaps I could have done a better tension, but in fact, the cystocele won't move because it will be fixed by the mesh. What is important is to go as down as possible, because at the beginning of your experience, if you don't place very well the blade, sometimes you will do the dissection and say, oh yes, I have finished the dissection. You place your mesh, but in fact, it remains quite 2 or 3 centimeters of dissection because you have not developed the vagina with the blade. So that's why it's very important, and that's why I like to do it by laparoscopic approach, because when I don't see very well, I take myself the blade, I replace it, I push the vagina, and I'm sure that I'm well placed. But with the robotic access, you are on your console. You can't know if the nurse is doing well, and sometimes it can be difficult. That's for me an argument against the robot. Perhaps we can go on if you agree, because I think time is running. Just to show you now the robot with the access. So the position of the ports, one is at the level of the umbilicus. We place 2 ports. It's a XE system. We place 2 ports on the left side, 1 port on the right side. So these 3 ports are for the robot, and in fact, the assistant has just 1 port which is an air seal system. It can be another thing, just to place the mesh and the thread. So this woman, it was a difficult case. She had hysterectomy 10 years ago. She had a prolapse 1 year ago, treated by vaginal mesh, and she has a vaginal erosion. So the mesh was taken out 6 months ago. And after this, she has vaginal stenosis and a recurrence of the prolapse, cystocele 2 and rectocele 3. So we imagine to do the surgery. So I will show you now. Okay, so in fact, it is exactly the same, and there is no difference. Huh? What I can say is that here you see the difficulty is to know, because you don't feel, and sometimes it's difficult to feel for me to feel where is the. So sometimes I ask my assistant to come with the suction or to come with the grasper and to do a pressure on the tissue to be sure that I am really at the right side. So here, I think I will show you. I will go outside of this because I can't go on here. So if you agree, I will try to show you this video outside of the presentation. Then I can go on and I can.
Okay, as you want.
I will try. Huh? Okay. Because just a minute. Okay. I will, okay. If it's not okay, I come back to the.
Okay, in this time I will ask something to Elisabetta. Sometimes we listen by some surgeons that the patient who we perform a sacrocolpopexy normally is aged woman, sorry. And why not perform a hysterectomy in all patients? I not agree with this point of view, but what do you do in your routine? You preserve the uterus normally.
I perform every kind of procedure. So because I think that it's important that you have to be able to perform hysterectomy if you need, or to preserve the uterus if the woman wants. And sometimes all the women prefer to remove the uterus because they asked me, they don't want to have this problem in the time, and I prefer to remove, and I remove it. And sometimes recently I perform also subtotal hysterectomy in some cases because it's sure that hysterectomy is the major risk factor for extrusion of the mesh. I think so that it's really probably the most important one. So if I can, I try to preserve the cervix to avoid this problem. But I think that it's an important message for every urogynecologist. You have to be able to perform hysterectomy because sometimes you open the patient and sometimes you have a surprise. And recently, a patient was completely well studied by the gynecologist, and when I entered in the abdomen, I discovered a tumors in the uterus, and I had to change completely my procedure. So I performed a radical hysterectomy, and then I was not able to put a mesh, and I positioned only some stitches on the uterosacral ligaments to correct the prolapse. So you have to be able to perform any kind of procedure when you decide to perform sacropexy, because sometimes you need. And
yeah,
thank you.
Elisabetta, I'm agreeing with that. I'm agreeing with that. And one thing that is important, every time that I perform a sacrocolpopexy, I ask to the gynecologist to perform the how you say, the control of the cancer of the uterus, you know?
Yeah, me too, me too. But sometimes you can have, in any case, some surprise. Because, you know, there are some cases in which this is not possible to discover some kind of little tumors. And sometimes another problem is the annex. Because, for example, I had some experience in patients in which I discovered something which was wrong on, like a fibrom in the annex. And in this case, you have to decide what to do. And so it's right, a good gynecological preparation before surgery, but always ready to do everything you need.
Of course.
I think that Eric is ready to continue.
Did you see the robot or not? Did you see?
Very nice, very nice.
Yeah, you can see.
Good. Okay, so this is a different access, because she had a hysterectomy previously, you see, and she had already surgery for prolapse. Huh? So here, what I'm totally agree with the comments you said. If I have to do a hysterectomy, I will do a hysterectomy. If I have to treat the prolapse at the same time, I will do subtotal hysterectomy. And if I have to do a total hysterectomy, I will just do total hysterectomy laparoscopically, opening the vagina, and then several months after, I will place the mesh in a second surgery. I won't place the mesh at the same time. There is too many risks to have an infection. So here, what we were talking about is the difficulty of the placement of the blade. You see here, it's difficult for me because I am with the robot. Yes, I have the articulation, but I have always one hand fixed. In fact, I am not better than with my laparoscopic approach. But here, everything is difficult. You see, this grasper is fixed, and in fact, the assistant is not placing well the blade at that time. So I must ask her to lift up as maximum, and you see the difficulty. But okay, it's possible to do the surgery. So now we'll just.
Sorry, Eric, a question for you, because I think that you use an optic 30 degree, is right?
It's a 0 degree.
Okay, because I use a 30 degree, and when I am on the posterior vaginal wall, I put in minus 30 degree, and it's a better solution if you want to have a better visualization of the posterior vaginal wall. So I use it.
Right. Yes, I think you're right. I will use it, but
because you completely you are able, under, and obviously sometimes you have to change the position of the instruments. But when I use the minus 30 degree, it's the best approach for the posterior vaginal wall, especially if a patient like this, in which you have a previous surgery and also previous meshes. And it's the best cases for robotic. But sometimes I do the same only with laparoscopy. I turn completely the optic and I use the 30 degree. and then I put on minus, so plus or minus as you want. Yeah.
Okay, great comment. So just this time is just to show you again the dissection, the posterior dissection. I think it's very important. You see the rectum here very well. You see the first levator animuscle there. And what is important is to go as lateral as possible, because this is the rectum here. So pay attention, the rectum is going really laterally. You see the rectum is just there, so you have to go laterally. And then slowly pushing inside the rectum. This is the rectum still. So just going laterally, you will go and you will be able to find really well. You see now very well these two holes. And what I like to do now is to dissect really as maximum as I can the rectum to place a mesh. And now I place a mesh which has no incision, so which is straight. You will see.
And if you have a lesion of the rectum, not you,
No.
but a less experienced surgery, what to do?
You have not to place the mesh. You have to repair and to stop.
Okay, and you can repair by yourself, or you need a surgeon?
You are a surgeon, but if you make an injury of the rectum, you should ask a general surgeon to come and to do the surgery.
Okay.
Because it's a functional surgery, so you have to pay attention to have no problem.
Yeah.
So you see this dissection, and now we can just go. There is no real difference. So I will show you. I don't know what you want to see, but it's exactly the same. Perhaps we can talk now about the difference. This is a polyester mesh again. We'll show you.
And I have a question for you. If you have a patient with the previous vaginal mesh, which is sometimes is the case because it's a failure of a previous surgery, with no extrusion, so a vaginal mesh position, but with a recurrence. And I generally perform laparoscopic or robotic approach. Sometimes robotic is easier for me. And when I arrive to the previous mesh, I never touch it, and I decide to reach the previous mesh and stop to that point. Do you agree, or do you think that you perform other kind of solution in these patients?
I have done several cases of recurrence after meshes or after laparoscopic sacrocolpopexy and recurrence, or after meshes placed by vaginal access. In my experience, most of the time I go on because the prolapse is under the mesh. So most of the time I dissect the mesh, but I let it in place. I won't take it out. And I will dissect under the mesh to find the recurrence and to place again a new mesh, but I will fix it on the vagina and avoid to fix it again on the previous mesh. But I won't try to take it out. I think you can let it.
But it's not easy, because sometimes there are a lot of adherence between the mesh and the vagina, and the risk of a possible extrusion of the mesh is really high. So
the best is to follow the mesh. For example, if you want to dissect this mesh, you have to dissect from the posterior part of the mesh and not anterior part. Okay. You have to dissect far from the vagina. You understand what I mean? And you just follow the mesh with the section of your scissors, and in fact the mesh will guide you. In fact, you just go on, and it's exactly the same when you are doing prostatectomy with the previous hernia. You just follow the mesh. but far from the vessel or far from the vagina. So here we can just go to show you the anterior dissection, because here it's a difficult point. How to find the right layer? How to find so for me, it's very important here. When you have this kind of situation, you don't know where is. You see that the bladder is there, but you don't know exactly where to do the incision. Personally, I don't start again from the same incision. I will redo an incision, and most of the time, it's the level of the round ligaments. If you find the round ligament, it gives you the right layer. So here you don't see very well, but the round ligament is somewhere there. And if you follow the right, you can find the layer. The second option is to inflate the bladder with serum or with blue. Then you will see better the bulk of the bladder, and then you will be able to find it. So as I said here, you see, I won't start there. I will just restart. And if it starts to bleed, it means that you are in the bladder. So what I'm looking for, you see, yes, you see this round ligament. So I'm just trying to find the layer, but here you must remember that she has had a vaginal mesh with an erosion and with a second surgery, so it's a difficult case. But I will go on just to pass a little bit more. So you see, slowly now we can approach with the plate. You see this is the plate, the bladder. You see very well, and now you see very well the dissection. Probably with the scare, with the previous mesh somewhere there, and then you can go on with the dissection. But here I feel less confident with the robot. For me, it's my experience, because I don't feel very well. I'm just seeing. So I think we can stop this video. I will show you the second one.
Well, I make a comment.
Yes.
I think for the beginning, when you start to perform the surgery, to put the blade, to know where is the plane, and then you can not put a lot of tension in the blade to know
yes,
where is the layer.
Yes, it's a good comment. What is important is to have not a fixed blade.
Yes,
At the very beginning of my experience, we were using a fixed blade. I mean, it was fixed on something, and it was fixed. Okay.
Yeah. No.
And when you slice this, you are at risk to have an injury.
Okay, I understand.
What is important is to be able to mobilize the blade, to be sure that you are not pushing the rectum or something else. So you see this here, the dissection was very difficult. We will go on just to spare some time. Okay, now just the suture, but it was a very difficult surgery. I think there is nothing more to say because there is no difference. I think perhaps we can just finish the dissection just to show you here. Here's the difficulty and why I like very much the laparoscopic approach. So you see here, it was impossible to find really well the sacral ligament. It was very
Yeah, and this is the case in which the taker can be useful, you know. Sometimes.
You can have the iliac vein somewhere here. So you see the iliac vein is probably somewhere here. So I won't use a tacker without seeing the ligament. So you see, slowly I will try to,
sure.
but for me, I will be much more confident, but it's my experience. Huh? But I think it's, you see here, I asked my assistant to fix with the suction device to say me, is it the right level? I don't know. In fact, I don't know. Okay. I'm looking. I don't know. I don't see anything. You understand? This is a problem of the robots. You don't know exactly where you are. So you see, I asked my assistant to go, and you don't know exactly where you are. And with your scissors, with laparoscopic approach, you know where you are. And for me, perhaps I'm not doing a lot of, I'm doing more prostatectomy and partial nephrectomy than prolapse, I must say. Huh? But
I am sorry, but I have to say hello to everyone. I really thank you for everyone for your invitation, and I thanks really Eric, because I learn a lot every time that I see a good surgeon with a good experience as you. And
thank you for your comments. I was very happy to be with you for this sharing experience, because you have also a good experience. It was great to share this together.
Okay, and
thank you very much for accepting. I met you in 2016 at Lisbon. You remember when I performed Sacrocolpopexy live, and you are very, very kind at that moment, and now to accepting our invitation. Thank you very much for your comments, for sharing with us your amazing experience in this field. Thank you very much.
I thank you, and really, I remember you very well, and you are in my heart, and no, I will remember forever. And I hope to have the opportunity to meet you, hoping the period will be best in the time, and to have the opportunity to meet not only on live, but directly face to face.
Yes, yes. When finish this nightmare that we are living.
For sure. I didn't ask anything about this because it's terrible everywhere. So I think that it's better to speak about Sacrocolpopexy. Yes, okay. Yeah. Hi, Clovis, Alejandro, and Eric. Bye-bye.
Bye-bye. Thank you very much.
Bye.
So we'll just finish if you want, because the problem remains, for me, the time and the cost. I must say, with the experience, with the 3 division now, my mean time is 45 minutes to place two meshes. Okay.
Eric, you said that you said that congratulations for the videos, very, very beautiful and nice. And I want to ask you a question. When you open the rectum, you said that you close the rectum and stop the procedure. But if you open the vagina accidentally, what do? Do you close the vagina and continues the procedure, or you do the same thing like the rectum? You stop and do sacral promoter fixation in the second time.
Just to complement, Ricardo, there's difference if you make this injury in anterior wall or posterior vaginal wall.
Yeah. Okay.
It depends on the hole you do. If it's a small hole, without carbonization, without big cauterization, if the vagina is okay, then you can close the vagina very well in 2 layers. Then I think you can place a mesh, no problem. Okay.
Okay.
If it's a very big hole with necrosis or carbonization because you have to do coagulation, then I think it's not a good idea to place a mesh because you are a high risk to have at least ulceration and exposition of the mesh. So it will depend. Okay. Also, you can do a hole in the bladder, no problem. You can place the blade, the mesh, but close your bladder in 2 layers. The only problem is for the rectum. For the rectum is I must say that I've never had any injury of the rectum, never, for more than 25 years of experience. So that means that if you pay attention, you could not have any injury of the rectum. I have had injury of the bladder. I have had injury of the vagina, but never had any injury of the rectum. But if you have one, just close in 2 layers the rectum. Ask a general surgeon to know if you have to do a colostomy or not. And don't place a mesh.
Okay. And for the surgeons who is beginning to do this procedure, I know that many of them, when are doing the posterior part, they start dissecting lateral to the rectum, and then fix the mesh laterally to the in the muscle, but laterally to the rectum. And what do you think? We have to dissect close to the posterior wall of vagina to reach the right point to fix the mesh, or do you think there is another maneuver to know what the correct point to fix the mesh posterior at the muscle? What do you think?
We have different approach because we have a talk about in the AFU Congress 3 years ago concerning the rectal cell treatment, and we have a discussion between general surgeon, urologist, and gynecologist, and it was very interesting because the general surgeon were doing the same dissection, arriving to the pelvic floor muscle, but they were fixing the mesh on the rectum. Yeah. And we are fixing the mesh on the muscle, pelvic floor muscle, and on the uterosacral ligament. They are fixing the mesh on the rectum, like Orlog technique for the prolapse, rectal prolapse, if you know this. So that means that you can fix the mesh. You can fix the mesh on the rectum. It's possible, and it's not at risk. But the normal dissection for the urologist is to lift as maximum as you can the vagina, to follow the vagina, to arrive to the end of the dissection of the rectum, and to find on both sides the pelvic floor muscle, and to fix your mesh not on the muscle, but not on the vagina, but on the muscle. But that's a technique. But as our colleague from Italy said, she has no problem with the fixation of the mesh on the vagina. So perhaps we have to imagine another way to go on. I don't know.
Okay, and Eric, the last question: do you always perform the correction of the posterior part of the posterior compartment? Always, even if the patient doesn't have retocell or
no,
a posterior defect?
I must say that I'm convinced. I explained that for me, the posterior mesh is the most important part of the reduction of the prolapse, because all the forces are going posteriorly. Mm-hmm. That's why 20 years ago, 30 years ago, when we were doing a prolapse by vaginal approach, we were doing a myography, because we know that posteriorly all the pressure goes there. But the myography was very bad for the intercourse, and so we imagine to stop this surgery. But the posterior mesh is important. But you're right, sometimes I won't place a mesh. And when? I won't place a mesh if she is a young woman, for example, 35 or 40 years old, with no rectocell, with a good uterosacral ligament, then perhaps I won't place. The second thing, if the patient has a big constipation, she arrives and she said, "Oh, I'm going every 1 week to the toilets." First of all, I will ask a consultation with a gastroenterologist to ask for a coloscopy. And second thing, I won't place a posterior mesh, because if you place a posterior mesh, it will be worse for the constipation and it will be a nightmare. So these are two indications not placing the posterior mesh. Very young women with a good uterosacral ligament with no rectocell and big constipation previously to the surgery.
Okay. And Eric, what do you think about dynamic MRI in pre-operatory, like a pre-operator exam? Because sometimes I think it's difficult to clinically make the diagnosis of rectocell or cystocell or both, the association of both. What do you think about the use of dynamic MRI to make the diagnosis of the defects in the posterior or anterior or median compartment? Do you think it's important or no, just we can do the diagnosis clinically?
I think if you have a good experience, you can do the diagnostic clinically. You can do a bidigital examination, rectal and vaginal. You can find the rectocell, you can find erythrocell, but with a blade anteriorly pushing the cystocell and so on. But it takes time to be able to do this. But I am able to do this because I'm doing this for now 30 years. What I think is now the MRI is important because if you have, for example, a problem with the lower, you can say this woman had a cystocell because on the dynamic MRI you can see the prolapse. So I think now it's important to have exam previously to the surgery, and what is recommended now is to have an MRI. So I will do. Now I will ask systematically, as I said, urodynamic test, ultrasonography, and if I can, MRI.
Okay. Thank you.
Okay.
Thank
Rick,
you.
one question. Maybe
Yes.
maybe you will talk. But do you indicate kinesiologist or physiotherapy after or before the surgery?
Before surgery, I won't ask a lot of things. If the patient has a bad vagina, I will ask to place some drugs in the vagina. I mean hormonal treatments to prepare. If it's because of the menopause, so I will ask 1 or 2 months before the surgery to place two per weeks some gel in the vagina to help to have a better trophicity of the vagina, first of all. And second thing, I will ask after the surgery to pay attention, to have no efforts during the first 2 months, because I think during the first 2 months the mesh will fix. I'm not totally agree with the Italian surgeon saying that in 15 days the mesh is fixed. I'm not totally agree because I think it takes more time to be really fixed. And during this time, during the first 2 months, you have to pay attention to avoid any efforts, any sports, because it's the time for the mesh to be fixed. And then after, they can start again. But for example, tennis or golf, you should ask for them to stop for 3 months, I think.
Okay, totally agree.
Eric, do you think that the use of estrogen before the surgery, especially for the older patient, do you think it's important to reinforce the vaginal wall or not?
Yes, I'm sure. Yes, if it's possible, I think it's important to place estrogen in the vagina to prepare the surgery. I think it's very important.
Okay.
Yes. So, in conclusion, I just want to say thank you for your invitation. I hope the video were not too bad. The first one is an old video because now I'm only using a 3D vision and my video are with 2 eyes, and it's difficult to show you because you have 2 video at the same time. So that's why I found this old video, because the one you have seen is 10 years ago. Huh? So now it's much more beautiful, but it's like this. But what I must say that really, with my experience, I prefer laparoscopic approach, but I know that the new surgeon and the new generation will do it by the robotic approach, and I think it's the same. Huh? What we can say is that it's very important to keep for the urologist this surgery, and to work well and to have better communication, because it's very important to keep this, because if we don't keep this, because the gynecologist won't place anymore the mesh by the vaginal approach, they will do it by the robotic approach, and they will have the patient because they have more women than we have. So I think it's very, very important to fight and to be all the urologists together against to say that we are good surgeon, we are doing well this surgery, and I think we are doing better than the urologist, than the gynecologist. I don't know, but I think. What do you think?
The same.
Okay, so perhaps we can see us together at the end. Just
Eric, thank you very much. Was a very, very nice meeting tonight. We discussed a lot about technique, experience in this field of the urogynecology, and I must say thank you for you.
I hope I answer your question. I hope I have done the good job. I don't know, but
you show very nice videos. You show very nice videos, really, and made nice comments. Okay. We learn a lot with you tonight. This meeting is a little more important than others. I'm joking, because today, as the first year, we completed 1 year of this meeting. We start when the pandemic was in high level in 2020, and by Tobias' idea, we start this meeting. So today is our birthday. So thank you very much. Yes, thank you, Alejandro, my friend. Thank you, Tobias, Ricardo, for the audience. Thank you very much for the participation. See you.
Bye. Thank you.
Thank you. Bye. Thank you, Tobias. Ricardo.
See you guys.
Nice to see you.
Bye. Nice to see you too.
Nice talk.
Okay.